Hello and welcome to today's webinar, Reframing Aging, a primer for healthcare professionals. Every day, all day, we communicate, and we make choices whenever we communicate. We choose the approach we take to conversations, we choose which words to use, and we consider the results we want to achieve through our communication. We have learned through the research of the Frameworks Institute that words matter, and that certain communication approaches work better than others. This webinar today focuses on the communication choices of healthcare professionals. If you are a healthcare professional, you are most likely on the front lines of the COVID-19 pandemic. You are aware, as many of us are, of how the pandemic has exposed ageism. Our goal today is to introduce you to the Reframing Aging initiative and offer an approach to communication that allows you to address ageism and negative attitudes towards older people. Specifically, this webinar today will cover 4 ideas to consider when talking about older people and health equity in healthcare during the pandemic. I'm Trish D'Antonio, Vice President of Professional Affairs for the Gerontological Society of America and Project Director for the Reframing Aging Initiative. Before we begin, a few housekeeping notes. All participants are muted for the presentation. A question and answer session will follow the live presentation. You can type your questions using the questions feature in the dashboard accessible on the right-hand side of your screen. We will not be using the raise hand feature today, so if you do have a question, please use the question panel. This webinar is being recorded and will be posted on the GSA website and the Reframing Aging Initiative webpage. A handout of the slides will also be available at that time. A notice to all attendees will be distributed when the recording is available. A survey will automatically launch at the conclusion of the webinar. In an effort for continual improvement, we would love to hear your thoughts. Please provide feedback by clicking the survey link at the end of the webinar. The Reframing Aging Initiative is a long-term, evidence-based social change endeavor designed to improve the public's understanding of aging and the contributions that older people make to society. Ultimately, this greater understanding will counter ageism and guide our nation's approach to ensuring supportive policies and programs for us all as we move through life course. This work is conducted by the Gerontological Society of America on behalf of 8 national organizations, collectively known as the Leaders of Aging Organizations. The founding LAO members are AARP, the American Federation for Aging Research, the American Geriatric Society, the American Society on Aging, the Gerontological Society of America, Grantmakers in Aging, the National Council on Aging, and the National Hispanic Council on Aging. The LAO collaborated to create the Reframing Aging initiative starting in 2012. The Reframing Aging initiative is presently supported by the Archstone Foundation, the John A. Hartford Foundation, the RRF Foundation for Aging, and the SCAN Foundation, with additional funding from the New Hampshire Endowment for Health, the Next 50 Initiative, the Rose Community Foundation, the San Antonio Area Foundation, and the Tufts Health Plan Foundation. We thank them for their generous and continued support. We bring this important webinar to you today with our research partner, the Frameworks Institute. The Frameworks Institute is a nonprofit think tank that advances the mission-driven sector's capacity to frame the public discourse about social and scientific issues. We are pleased to have been working with the Frameworks Institute since 2014 to bring this research to the field and develop ways to apply framing techniques proactively. And so it is my honor to introduce to you today our speakers, Dr. Maura O'Neill and Dr. Helen Fernandez. Dr. Helen Fernandez is a physician and professor specializing in geriatrics and palliative care medicine at the Mount Sinai Hospital and Medical School in New York. Her career interests include faculty development, evidence-based medicine, learner assessment, and medical education. She has developed and taught interdisciplinary curricula for a wide range of programs, including geriatric fellowships, rural healthcare, and the Indian Health Service. Dr. Fernandez has been what we like to call an early adopter of the Reframing Aging initiative, having been trained as a Reframing Aging facilitator more than 2 years ago. She has conducted numerous trainings for healthcare professionals in conjunction with the American Geriatric Society, a founding member of the LAO. We are extremely pleased and fortunate that she is here today to provide her perspective on challenging ageism and advocating for older people in a healthcare setting. And next, I'd like to introduce Dr. Maura O'Neill, who serves as Vice President of Interpretation at the Frameworks Institute. In this role, she leads Frameworks' efforts to interpret and share communication science with the nonprofit sector so it can more effectively drive social change. Maura manages a team of communications professionals and social scientists who help fields of practice frame social issues in ways that have the proven power to deepen understanding and inspire action. She oversees the team's efforts to synthesize framing research, teach advocates to apply the strategic communications, and train sectors to unite around evidence-based framing recommendations. As a senior researcher, Maura also directs the organization's efforts to analyze framing patterns in the media and nonprofit sector, and writes in-depth research reports on a wide range of topics, including immigration, child mental health, and housing and homelessness. A sociologist with expertise in how frames impede or advance social movements, Maura has helped hundreds of organizations strengthen their communications capacity. She regularly delivers presentations and lectures on issues framing at nonprofit organizations, colleges, and universities around the country and abroad. I invite you to read more of Maura's accomplishments on the link to our webinar announcement on the Reframing Aging website. So with that, I'd like to ask Maura if she could take it away.
Yes, thank you, Trish. So I want to start with a round of thank you. So I want to thank Trish and Lori and everybody at the GSA for inviting me here to talk to you. I really am pleased with my getting to present with my co-panelists. My plan for today is to talk kind of at a high level of some strategies that we are recommending that framers used to combat ageism, especially in the context of the pandemic. But Dr. Fernandez has experience actually implementing these strategies and also teaching other healthcare professionals how to use these strategies. So I think that her contribution to this conversation is going to be very helpful. And finally, I want to thank all of you out there. I know that this is a very stressful time for many people. Many people are juggling a lot of their work and their caregiving activities and responsibilities, but you all might be experiencing this at even higher rates of stress than some of us. So I know that taking an hour out of your day is a very big deal. So just thank you so much for being here. And I hope that, at least one thing I say can be a bit helpful for you all as you go and do your work. So as Trish said, Frameworks is a nonprofit communications research think tank. Part of my job at Frameworks and part of our team is responsible for going out into the world and figuring out the most effective ways to frame social issues. We figure out how do people who are non-experts, who don't get to sit, breathe, think, talk about certain issues all day, how do they already think about those issues? What do people with some kind of expertise on those issues, what do they want to say? And how can we develop strategies and test them to see whether we can bridge the gaps between those two forms of knowledge? And the other part of the organization is the team I lead, where we try to make that research really actionable and usable for folks on the ground who have to do the very difficult work of changing for some kind of social change. So I'm going to start, before I get into the 4 strategies, I'm going to back up a bit and talk a little bit about definitions of framing, why it matters, why research is important when you're making communications decisions, and how framing can help address some communications challenges that you may be having. So to start with, when I say framing, I really mean every decision that you make as a communicator when you are out in the world, talking to anyone really. So it's the pronouns that you use, the values you invoke, the way you explain things, the way you don't explain things, the things that you leave unsaid. All of those are decisions that we can make consciously or unconsciously. We can make them strategically or not. And the reason it's so important, because those choices in how we present information, they're not insignificant. But we know in the social sciences and the cognitive sciences, and I'll show you some examples of this in just a minute, that these choices impact how people understand what you've just said, how they think about the issue that you are talking to them about, how they feel, and what they might do with that information. So I've been at the Frameworks Institute for about 12 years now, and I always say framing matters, but it really, really is important right now. And the reason it is so important is that we know at times like these of immense social disruption, that change is going to come in some form. We will never get back to the new normal. But one thing that we do have control of is how we frame those issues and the direction that that change goes into. So, for example, we know that wars tend to be a similar kind of disruptive event, exogenous event that changes social order, how we organize ourselves, what our culture looks like. So we know after World War I, we saw the rise of authoritarian governments across Europe. So not a great, not a great trajectory. We also know, though, after World War II, that many of the things that happened really served as a catalyst or an accelerator of many of the rights-based movements that we saw following the war. So more women went into the workplace. They got more involved in the women's rights movement. When Black soldiers returned and they were veterans and they were denied many of the rights and of their service to the country, and they became a very powerful symbol of how Black people were expected to carry the responsibilities of citizenship but not given any of the rights. And again, that was an important symbol of the civil rights movement and framing about why that movement was so important. So I give those two examples just to say that we can go in a lot of directions from here, but our communications choices matter, and how we communicate together as a field of practice can make sure that we go in directions that we'd like to see. And importantly, what I'm going to talk about is, while we are seeing just horrific and explicit and in-your-face ageism, in the news, when we turn on the news, when we talk about the quote-unquote sacrifices that we want older people to make, it can feel very disheartening. At the same time, I think there is an opening here, because we are having conversations about ageism that we did not have prior to the pandemic. And so I want to talk about some strategies that we might use to make sure that we go in the right direction when it comes to addressing ageism. So I talked about you all out there as heroes, and you're also framing heroes as well, because you have incredible reach, right? You talk to so many people. You talk to members of the public. You talk to patients. You talk to family members. You work in settings with colleagues who may or may not have expertise in aging issues. You are an important source of information in our society. And so your ability to make sure that we do go in the right direction right now is just immense. But I want to talk a little bit about the kind of framing advice that I will be giving in just a minute. So you all out there are probably very familiar with the need to communicate with people so that that message or that information results in some kind of individual behavior change. So you may need to talk to someone about starting a new medication. You may need to talk to someone about why they need to engage in certain activities for better health outcomes, or that they need to stop engaging in some activities to avoid negative health outcomes. That is extremely important, but the framing I'm going to talk about today and these strategies are really more about talking to people about the kinds of supportive policies we need for older people, the kinds of systemic changes that we need to combat ageism, and to also make sure that people have everything that they need to age in the ways that they would like to. So again, while communicating for individual behavior change, giving people information, and that person as an individual is going to do something different is very important. Today, we're going to talk about how can we talk to people as engaged citizens, as engaged members of their community who can really work with us to enact the kinds of policy and systems change we would all like to see. So I'm going to start, though, I'm going to take a small break, very short break from talking about aging and ageism, and I'm going to talk about, to draw on a couple of examples outside of aging to show you why framing is so important and why really looking to research is important when you're making framing decisions. So what I'm going to show you in just a minute is an example of sort of a classic experiment that comes out of the political scientists at the University of Michigan. And so what they did is they had a group of people that they were surveying, and they asked a sample of those people get the question, given the importance of free speech, would you favor allowing a hate group to hold a political rally? So the frame there is the value of free speech. They asked another group of people, if given the risk of violence, would you allow that a rally to happen in your community? And what we see here is incredible differences in response. So for those of you who are data geeks, nerds, dweebs, and I consider myself one of you, you know that if you see this difference in response, you can publish this study pretty quickly. This is massive. And again, it's just the difference in a few words that shapes these differing responses. And again, this isn't inconsequential. This is people's policy preferences. It's what they will allow and what they will not allow in their communities. And just these small word choices has this big of an effect. I'm going to give you one more example from some of the work that we've done at Frameworks at the other end of the life course on children's issues. This particular survey that I'm showing you right now is from some work that we've done on framing children's mental health. Now, when we started this project, the challenges that we saw in public thinking were very, they were big obstacles to getting people to think about children's mental health. So two of these challenges that were really impeding people's ability to communicate effectively about child mental health policies is, first, when we asked people, what do you think about children's mental health? Most people said one of two things. First, they said, children can't have mental health. What are you talking about? That's an adult thing. They don't even have mental health. Why are you making them into little adults? So just the idea that this thing is a thing that exists was hard for people to think. The other thing that we found happened is that when we said children's mental health, what people heard was children's mental illness. When people tend to think about mental illness at any age, They tend to think it is genetically determined. They become very fatalistic, and the idea that if a child is having mental health challenges, that they're likely going to be doomed for the rest of their lives. So an incredible amount of fatalism goes along with people really sort of grappling with the idea of children's mental health. So what we wanted to do is we wanted to test some framing strategies, and here we're testing values to see whether or not we could lift people's support for evidence-based policies that would better support children's mental health. So we tested 2 values in this particular experiment. So the first value, and so a small group, a subsample of our survey participants, they received a message of future progress or social prosperity. This is kind of the children are the future kind of message. As if we support children's mental health, it is extremely important because we know that young people, children, are the foundation of our society. They are what we are going to look like in the future. So supporting their mental health really matters. The other framing strategy that we tested, and we tested this particular strategy because a lot of advocates, experts, scientists, healthcare professionals in the field were using the frame of vulnerability. So we need to protect vulnerable children. The black line that you see going across your screen, that is the control group, and that group received no message. And then we asked everybody questions that measured their support for evidence-based children policies that would support children's mental health. And then we saw the results, and I will show them to you here. Now, if we were all in a room together, which I wish we could be, I would say audible gasp now. So you guys can gasp audibly, but I won't be able to hear you because you're all on mute. But what is remarkable about what you're seeing is that the frame that advocates, again, scientists, healthcare professionals who are really interested in better supporting children's mental health, the vulnerable child frame was actually depressing people's support for those very policies. And the reason that was, we found in later stages of the research, is that when we went out in the world and we talked to people about, a child is vulnerable, why are they vulnerable? We heard a lot of talk, and mostly talk, about bad parents and parents being selfish and parents not doing their jobs. And the problem with activating that way of thinking is it's really difficult for people to think at a level of policy or systems change. If it's about bad parents, then what we really need to do is just punish those parents, and sort of what surrounds those parents, the context in which people are making decisions about their parenting, fades from view. On the other hand, this social prosperity message helped people see this as a policy issue, as an issue that we need to think about at a systems level. And the other reason that we think framing is so important, because when we work with groups of all sorts, but I'm going to focus on healthcare professionals, we often find, or they come to frameworks because they're having a problem. And that problem is what we call the you, say, they think problem. So they go out into the world with what they think is a wonderfully crafted message. Maybe it has words that you and your colleagues are very familiar with, and you go out and you speak to people who don't share that level of expertise. Again, don't have, and I don't say that in a sort of a deficit way, but most members of the public can't think about most issues most of the time. I consider myself one of those non-experts on the issue of aging and ageism. But we do make sense of your information. And the problem is sometimes there's a lost in translation moment. And so I want to talk today about 4 ideas about framing ageism in this particular context, in the context of the pandemic. And again, I'm so thrilled that Dr. Fernandez will be able to talk about what does this actually look like on the ground from her perspective. So the first challenge that we see across issue areas, but this was really very apparent when we were talking to members of the public about aging, and especially thinking about health outcomes as people age, is that people really narrowly think about health outcomes as solely determined by people's individual choices. And did you diet? Did you exercise? Did you not smoke? Did you not drink? So when you all in the world might be talking about or might be working on how do we address the social determinants of health, was very difficult for people to think about. And what we found when we would look through advocates or experts' materials is that often they would be inadvertently supporting this idea that people's health outcomes are only about individual choices, that nothing else determines that. Now, of course, our health is determined by our choices, but again, we make choices in very specific contexts. So one of the things that I think is really important to do in communications is to really carefully attend to attribution of responsibility in your communications. And what I mean by that is if you lay out a sentence, really think about how is a person going to complete that story? Where are they going to attribute responsibility? If you're laying out a problem, what are they going to think about? Cause that problem? How are they going to think about who's responsible for addressing that problem? And how are they going to think about what are the solutions we put forward? So I'm going to give you a concrete example of this, but some of the strategies we use so that we get out of the frame of people blaming solely individuals for their health outcomes is to tell stories that bring systems into view, that bring the social determinants into view. And really, because when we're talking about differences in health outcomes, we are talking about health equity, it is extremely important to leave no space in communications so that people can blame marginalized groups for what is really the result of inequitable systems. So I wanted to just show you an example that I'm seeing quite often in the news right now. So the before that sort of leaves the attribution of responsibility, open to interpretation. So in the before, the sentence reads, the higher number of deaths among older people and Latinos can be explained by the higher number of underlying health conditions, like obesity and diabetes. Now, there's not really a clear attribution of responsibility here, but when people hear obesity and diabetes, they are going to immediately focus on people's dietary choices, not their food environments, not what their neighborhoods look like, but about individual choices. And again, I think this becomes especially detrimental when we are out talking about racial disparities in this pandemic. So another story that can be told about why the virus is disproportionately impacting communities of color is to sort of bring greater attention to what people might be experiencing. So instead of focusing on, not that you shouldn't focus on underlying health conditions, but in addition to focusing on that, I think it's important to talk about why people get sick in the first place. So what conditions are they living in? How do they get to work from home? What are their working conditions like? And so that's just another story to talk about why this virus is disproportionately impacting some groups that doesn't leave space for people to blame people for their decision making. The second framing challenge I think that you all are facing is that right now, this is it should be this way, but the only stories we are hearing are about older people's vulnerability. They're being at risk for the virus. And there's actually a lot of other stories about the role that older people are playing and the experiences they are having during the pandemic. And I think that those stories need to be told as well. So I am working on a project right now where I'm helping some psychologists at the University of Oregon who are surveying caregivers of children from 0 to 5. And obviously, lots of us, myself included, have lost access to our childcare. And what they found in this survey is that grandparents at great risk to themselves are often filling this gap. And I think you all have lots of these stories as well among healthcare professionals. So this was just a blurb I took from the news. New York and Florida issued calls for retired medical professionals to return to work, and thousands volunteered. And many people are acting as caregivers for their family members. I would slightly reframe how those family members were described. Person first language is really important here. But this blurb does point to other kinds of stories about the role that older people are playing during the pandemic. The third challenge that you all are facing as you go out and you talk to so many people about ageism, again, in your own workplaces, in your communities, with family members, is that people are incredibly fatalistic about health outcomes for older people. I find myself, falling into this trap constantly. So I have a mother with COPD and a father who's is permanently on immunosuppressants. And so I'll talk and I'll say, if they get the virus, it's a death sentence. So again, this fatalism, and that might be the case, but that this fatalism is so strong, it's hard for people to see a way forward. And here, I think it's really important that in our communications, we find a balance between communicating how urgent the situation is, right? Making people understand the extent of the problem, but also helping them understand that we do have solutions, or we do have ideas of how we might improve situations, how we might move forward. And getting this balance is really important. So if you are engaging in crisis communications, that it is all, the problem is so big, full stop, that we know that this can contribute to fatalism. If it's all about, we've got this, we found solutions, problem solved, then people don't understand what the problem is, and if there's no problem, why do we need to act? So there's a lack of motivation. But getting that balance right can lead to deeper engagement. Now, prior to the pandemic, when many of us would go out and train people on these principles, we would really focus on avoiding the crisis language, right? So stop saying silver tsunami when you're talking about coming demographic shifts. Stop talking about we're going to fall off a demographic cliff. No, natural disaster metaphors are really not what we want to be using right now. I think in this particular moment, striking the balance between urgency and efficacy shifts a little bit, because if you do not sufficiently acknowledge the severity of the problem, the severity of the challenges we are facing, you could sound tone deaf. At the same time, we still want people to know that there are things we can do. So here is an example of how you might achieve that balance. So obviously, and many of you probably are working on how the virus is impacting people in nursing homes and other kinds of facilities. Again, these are two blurbs that I've taken and sort of adapted a bit. The first one on the top talks about, again, the risks of being infected and of dying, that the virus is particularly lethal for older people. It spreads through facilities where many people live in a confined environment and workers move from room to room. So there we get how severe the problem is, but we can't see any way out, right? This is they describe the situation that people find themselves in, and it's hard to think about what we might do to prevent both infections and deaths. So the after is very similar, right? The first sentences are exactly the same, but instead of focusing on how the virus spreads, it focuses on how we might stop that spread. So a strong infection prevention and control program can protect residents and healthcare personnel. And then you can open up a conversation about what are the measures that we need to put in place to be able to address, again, the disproportionate impact of the virus on people who are living in these facilities. And the final challenge that I want to talk about, and then I will turn it over to Dr. Fernandez, is that what we find is that people at times, and I think this is shifting, but it is there, that they dismiss ageism as a serious issue. And sometimes this happens because people, advocates, I mean, very well-intentioned advocates, will talk about ageism as if it were just comparable to all the other isms. And there's a couple problems with that strategy. First is that people dismiss ageism. So you can't possibly tell me that it is as big of a problem as racism or sexism. So you're kind of putting this in this head-to-head battle. And second, it does miss the fact that many of us live sort of at the intersection of various axes of inequality. So it's not that we are walking through the world and now we're experiencing ageism and now we're experiencing racism, and then in this other experience it's sexism, that these all happen sort of they intersect each other. So how can you do this? So the first one, again, it's a call to action about addressing ageism in healthcare settings, and it's doing the comparing. It's just as bad as sexism and racism, and we need to combat ageism just like we do these other isms. But it is setting that up as discrete forms of inequities. Another way to do this is to talk about intersectionality, right? So older people are diverse in many ways, including race, ethnicity, socioeconomic status, disability, gender identity. Addressing marginalization and discrimination in the pandemic must focus on all of these sources of inequity as well as age. So here, you're not saying it's one or the other, but you're talking about how these systems of inequity are intertwined. So I'm going to stop there. I'm going to first, and Trish will talk a little bit more about this after Dr. Helen Fernandez speaks. But I would really, really, really advise you all to go visit the Reframing Aging Initiative's website. It's just an incredible source of information. We at Frameworks just started a new newsletter on Frame, and you can sign up for it. It offers framing advice across issue areas, but I think it might be helpful for you all as you go out and do your work. And with that, I am going to turn it over to Dr. Helen Fernandez. Thank you very much for having me here, everyone.
Thank you, Dr. O'Neill. Thank you, everybody. I'm so happy to be with all of you. And I want to thank, obviously, Frameworks Institute for helping to teach me some of these concepts and learning new things now also on this call. And thank you to GSA for inviting me as well. And I really want to kind of talk on the perspective as a healthcare professional and how I utilize and what my experiences have been around reframing aging. And I first want to start with, why did I get interested? in learning more about and becoming a facilitator. And I think I've been in this field for 21 years, and I was always drawn to doing geriatrics because I really feel that this population is vulnerable, can be marginalized, and that I can improve the quality of care, and that I can teach others how to improve the quality of care. And that is a population that needed to be listened to, and that what I had learned really, even though with good intentions, at times, as Dr. O'Neill said, we learn kind of how to speak to each other, and that the mission or the target was always off a little bit because people were really seeing it as much more a loss of function, being fatalistic, or even using the terminology. I remember many years ago, before I was actually did the training frameworks, of using that terminology of tsunami, and on a public report that I was doing on a show, and the host said to me, "Ooh, that's not something I want to happen to me. I don't want to be thrown into the tsunami." And so realizing how important words were, and that I needed to, as I carefully speak as a palliative care physician when I'm doing end-of-life discussions, and choose my words carefully, how I needed to choose my words carefully as I talk about the work that I do in geriatrics. And so I've been a facilitator and taught other groups about these concepts, and as well as a clinician. And and then personally, as somebody who's a caregiver to 3 octogenarians, I have examples of really how aging is heterogeneous. And I use my father as a great example. He is not a super ager. He's 89. He just turned 89 during this pandemic. And he just retired practicing medicine. And he is cognitively very intact, but definitely functioning needs a lot of help. And so he's a good example of what I think about ways of how aging looks like. You know, he's not the man who's in the gym lifting weights and running marathons, but he is not the frailest, and he isn't somebody who has multiple comorbidities. He's kind of in the middle and kind of getting along and adapting to the changes that happen with aging. And so he is representative of kind of the scale of aging that my patients have. And when I think about how I've used my training, I first start with vocabulary, right? And so I talked about kind of using, avoiding those words as tsunami, but even the words that we use to describe geriatrics, right? I just looking back of kind of words that we looked in the literature articles of how we use the word senior, elder, how we name some of our innovative care models, like acute care for the elderly or ACE units, as this wonderful interdisciplinary teams that will take care of patients within a hospital. Just realizing maybe we need to kind of rethink of how we would envision that and be more inclusionary, and learning kind of more kind of inclusive vocabulary to use. And so I use those concepts of language and a vocabulary when I'm teaching my medical students, when I'm teaching other healthcare professionals, when I'm doing my rural training, to think about maybe what unit, what team they might be calling their team or their clinic on how they're describing a certain population. And then I also think about kind of where have I hit these issues of, in particular, ageism. And even before COVID, but especially more now during COVID, where older adults have been marginalized. I think a lot about how we had a big uptick. I'm here in New York, so we suffered through a major surge. And one of the biggest barriers for us was really increasing our capacity with telemedicine. And several thoughts, out there of, our older adults, digitally incompetent, right? That's what people think often. Are they going to be able to get on all these platforms to be able to speak? And I think more about the issues that we had, where sometimes it wasn't even, that they weren't able to get on because they didn't know how to use it, but did they not have the tools? Did they not have access to a laptop, to an iPhone, to a tablet? And that speaks to more societal needs of accessing of those platforms. Not just are they able to cognitively do it, but do they have access to the tools that would give them the best access of care? And one of the things that pushed us to think was how do we become creative and innovative and use our ingenuity, because as Americans, we're very focused on problem solving. And so some of the things that we did during this time was thinking about other platforms of how to use not just our electronic medical record, using things that are HIPAA compliant, but using things that were, or connecting the family and the caregiver to help us get tools. We did a big call out for used iPads, for example, and getting them to patients, getting them some sort of tablet. We had them delivered through our paramedicine partners who do EMT, and they would go evaluate the patient and bring a tablet and instruct them how to use it. And we were then able to reach out this really marginalized group of patients that some might say, well, we can't reach them, we can't do anything for them because they don't know how to use it anyway. So that's what some of the creativity, and we have a long way to go on that, because there's still many segments of even in a big city like that, like this, in New York and in the United States, in big cities, that don't have access to these platforms. But it's an opportunity to see where these gaps of quality of care are and try to be innovative. The other piece that we really experienced a lot, during and have been seeing during COVID, is the thought that we needed to do resource allocation, and that a cutoff of age was the criteria that many people wanted to use. And really advocating, all of us as healthcare professionals, that it is more than just an age that marks you, whether or not you should get treatment, whether or not you should be have a ventilator or other treatments, that it is a context of who that patient is, with their comorbidities, with their function, and it is not just the age. And of course, the patient's wishes and their loved one and caregiver issues, wishes as well. And these were conversations. So sometimes I would be, I was embedded in the emergency room as many of these cases were coming in, and I would talk to my ED colleagues who were well-meaning, but would say, okay, so how are we going to have this, end of life conversation? And I would say, let's back off a little bit. Who is this person in front of us? And sometimes decisions had to be made quickly, but sometimes there's always an opportunity to have a discussion. And so I think this allowed us to think about, again, another gap, another area where we need to improve care, is reframing what the criteria are in these moments of resource allocation and several new criteria out there in terms of guiding healthcare professionals in making these decisions, in thinking about ethics and thinking about a more inclusive discussion that we should have. So I have these conversations with my other colleagues, at the bedside, in the ICUs, in the emergency room, of reminding people that in front of them is a person that lives within a context. And then some fun things that I kind of learned from some of my patients as I've been seeing them a lot more in person is that they themselves can be very creative. So many of them were telling me about how they were doing, still keeping connected via phone or via Zoom or FaceTime with their churches, their friends, their families, and now speaking to families even more frequently than they ever did before. How they were able to continue some of these virtual classes in terms of maintaining their function, and in terms of what exercises they could do at home safely without increasing their risk. And an opportunity, I think, also for us to think about and advocate for the caregivers, because more and more there's a reliance, especially in this era of the pandemic, where patients were sometimes without caregivers, paid formal caregivers because of safety issues, and their families, their informal caregivers, needed more resources, and advocate for those resources are really, really key. I think that we're at the cusp of really taking an opportunity and shining a light of, not saying it's a tsunami, but knowing that there's an urgency to change. It's pushed me in terms of being better at advocating for what my patients need, whether it be in some sort of tablet, some sort of device, training. I'll tell you another wonderful, many centers were having medical students and MPH students, nursing students, helping and teaching caregivers and other older adults how to utilize these platforms, and would help them get on to some of the visits. So I think that there is a great opportunity here to, in a way, improve healthcare in a much broader sense for our patients that are older adults. And I think that there's an opportunity of thinking about the health equities, looking at that lens and looking at marginalization as a way, because everybody wants to improve the care. They want to make the care better, and they are creative. And we just have to allow some of that creativity because it will come forward. And think seriously about how we use our words to really make it inclusive, to make it, to unpack it, to realize that some of the words that we're using may contribute to more marginalization. And what we can do is just say that this is an opportunity, that we're seeing these health inequities, and it's an opportunity to act, react, and improve. So I know I'm almost out of time, and I want to make sure that we give some time for questions.
Well, I just want to say thank you both to Mara and Helen for a great presentation. We're all facing this in practice regularly, and I think it's helpful to hear from you both on ways we can address ageism. So with that, I think one of the questions that I have here is, might be more for Helen. When you're talking with your colleagues and you try to get them to see the patient as a person, with a context not just of an age as a number, what kind of pushback do you get?
Sometimes the pushback, if there are urgent decisions to be made, where I don't have time to really get all that information, and I put myself in the shoes of, I'll get that information for you, and I'm sharing it, and I'm gonna help you understand, and then I get immense appreciation. I mean, our emergency room colleagues were so excited that we were willing to help get that information and put the patient within a context. And so I think they don't come from a place of not wanting to do that. They come from a place sometimes of not having time to do it.
Okay, good. Thank you. Another question, Helen, that we've gotten is, when you're doing this in the moment training, how do you get it to stick?
One is my presence. You know what I mean? That just being present, showing myself, teaching as many people as possible. So I run a very big fellowship, and I teach a lot of students in all disciplines, and I've indoctrinated them. And I even stop when they're presenting, and I said, well, every presentation, they know, they're like, okay, she's gonna catch me on this. And then and role modeling. I would say after I'm in a situation, I said, look how these are the words. Look out, what words I used to really engage, empower the work that we do. So I call attention purposefully, right? To what I say. And so it's very much role modeling. It's very much, I have now emergency room, providers who reach out and like, oh, can you come down and see this? Well, how can we do? I don't think this is the right decision. Like, they're so tuned into this now that they have an opportunity to think and take a breath and are realizing that they want to know more, they want to learn more. And so I think the biggest piece is that I'm helpful at the time when they most need help.
Mm-hmm. And the other thing that I'm constantly reminding people is this is a long-term social change initiative. And so it's going to take a generation for us to be able to see the impact of this work, to really get people to buy in. But we know that there are things that have started along the way, right? So I posted something in the chat around how some style guides have changed. And we know from our work that if research publications start to change, if research changes, how clinicians, how practitioners hear and read and learn about information, learn about resources, they'll model that language. So will the press. And in fact, the AP, the Associated Press, has changed their style manual as with respect to bias-free language around older people. Maura, or Helen, you might be able to answer this question. Someone asked about if you're familiar with any research with respect to now that people are staying home more or working from home more. Is there any impact that you've seen in reframing now that people are working from home, or any impact on socioeconomic impact that you could comment on? I know it's not in the original research that we conducted in Reframing Aging, but maybe there's some other resources that you could recommend.
I can look that up. I'm not familiar with anything. I mean, I know a lot of people have been talking about this actually being, again, another opening for reframing any issue, in that people are stuck at home. There's some evidence that they're more news attentive, especially because they're relying on the news for information about the pandemic. So sort of people's advocates, experts might have people's attention right now in ways that they might not have had pre-pandemic. But I can definitely look into other kind of research that talks about the impacts of working from home on people's.
Yeah, that'd be great. We're coming up to the end of the hour. I hope that all of you who have participated will join me in thanking both Dr. O'Neill and Dr. Fernandez for taking the time today. We have a slide up right now for you to see some of the other resources that are available in the Reframing Aging Initiative webpage. If you would like, we have a bi-monthly newsletter called Caravan. We'd like you to jump on the caravan with us and help us to reframe the public's understanding of aging. With that, I am going to remind you that we will be providing you with an email within 48 to 72 hours that'll include a link to the archives program and the slide deck. So thank you all for joining us today. We will respond to some of the questions we weren't able to get to in writing, and we look forward to seeing you in other trainings that we'll be providing. So this will conclude our webinar today.
Thank you.